Good morning, everyone. I'm Ralf Heine. I'm one of the gastroenterologists and allergists at the Children's Hospital in Melbourne. And I also would like to thank Nutricia for hosting this event and for flying me in all the way from Australia to give this presentation. I'm going to cover the global challenges in diagnosing pediatric food allergy. And I'm going to, of course, focus on cow's milk allergy, but we'll also cover some of the other food allergies. I know that this is mainly a group of gastroenterologists, but also some allergists and maybe some generalists. So I'm going to cover things pretty much from all angles, and maybe to start, give you just the roadmap of what I'm going to cover. So when we talk about adverse reactions to food, and when children with their parents come to our clinics, they don't tell us whether they've got an allergy or an intolerance or whether they use the right terms. And I find that the term allergy is often applied to things that aren't allergic. So for us as clinicians, we have to dissect out, is this really a food allergy? Is this an immune-mediated event? Or is this a food intolerance? Is this a non-immune event, something like a malabsorption syndrome? Or is this an idiosyncratic reaction to something like food additives or something ill-defined? And then if it is allergic, is it the immediate type of allergies that are mainly managed by allergists, or is it the non-IgE mediated form of food allergy? So these are really the decisions that you have to see, and as allergists, we now have to manage both sides, and in a way they're very different diseases, but often they're lumped together, and that's where often confusion arises. I've just put together here how patients might be triaged to different specialists, and that will also then influence how patients are managed. So if a patient has predominantly eczema, asthma, allergic rhinitis, or eosinophilic esophagitis, it's much more likely that these patients will be seen by someone with an allergy focus. Whereas if a patient comes with non-IgE mediated food allergy presenting with persistent vomiting, persistent diarrhea, rectal bleeding, feeding difficulties, failure to thrive, or eosinophilic esophagitis, again, they will probably be triaged to a gastroenterologist. And the approaches from gastroenterology and allergy are quite different. An allergist will often be focusing on IgE-mediated food allergy, give education about anaphylaxis and so forth, but will have often not a very sound backing, and this is from observation at our hospital, about gastroenterological conditions or nutritional management of these. Whereas that's what gastroenterologists are good at, but they often don't have a good understanding of atopic disease. So it is really where we have to pull together as subspecialists to have better synergy and maybe also to learn from each other and have less duplication between systems. And in Melbourne, we are lucky that we have people, like I'm a gastroenterologist, but I'm working in the allergy department, so we're trying to have now cross-linking clinics that are multidisciplinary. Cow's milk is a good example for IgE and non-IgE mediated food allergy and also intolerance. So cow's milk can cause all three, and that's where things often go wrong and get confusing. So I'm going to start with talking about the acute IgE mediated form of cow's milk allergy, and we'll later then, sorry, this jumped around a little bit, we'll talk about the non-IgE mediated forms later. So IgE-mediated food allergy and cow's milk is probably the, cow's milk allergy is one of the prototypes of IgE-mediated food allergy. It is interesting that only a relatively small number of foods causes the bulk of IgE-mediated food allergy. So in Australia, 95%, or in America likewise, 95% of food allergies would be covered by cow's milk, egg, the nut group, the seafood group, wheat and soy. But when you go around the world, the spectrum of food allergies is quite different. So for example, in the Asia-Pacific region, seafood allergy is much more common because fish is often one of the first weaning foods that is introduced. So the rate of food allergy is often represented also by dietary preferences. And that's maybe peanut is not a big thing in Argentina, so maybe that's why you don't see as much peanut allergy. In Australia, we see peanut and egg allergy at the top, but also cow's milk allergy. You can see here wheat in the middle, and wheat is a complex food because it causes wheat allergy, it causes non-IgE mediated wheat allergy, and it causes celiac disease. And again, likewise with cow's milk and wheat, we have the same dilemma that different syndromes can be triggered by the same food. The pathways for IgE-mediated food allergy are well documented. This has all been known since the 60s and 70s and been refined. And I just very briefly want to summarize it for you. So T cells usually present the antigen, the allergen, to B cells, which then go into plasma cells, produce IgE antibodies that bind to mast cells, and then with the allergen cross-linking the IgE on the mast cell, we get degranulation, and we get the effects of immediate food allergy. This pathway is very straightforward, and we can measure the IgE antibodies either directly in vitro, so that's what we call immunocap, or what was previously called a RAST, and or we can measure them indirectly through skin reactions. The clinical features of IgE-mediated food allergy, and I just wanted to briefly remind you, I know this might be very basic for some, but just to remind you what the clinical features are, and also the confusion what people call anaphylaxis is quite important. So most clinical reactions that are immediate type reactions to foods would be caused with urticaria, facial swelling, and lip swelling is an important clinical point, often pointing to food allergy, because the antigen presentation in the lip and oral mucosa causes the most swelling locally. Some patients will get oral tingling or itching, what's called oral allergy syndrome, and that is often triggered by certain fruit, for example, but it may also be a warning sign of an allergic reaction that might be impending to peanut or egg. So the treatment is cumbersome. It requires moisturizer, topical steroids, but very commonly, if onset is in infancy, it will have a food allergy background, and we should then investigate these children for their sensitization patterns. This is a study that was done a few years back. It was a multinational study or multi-center study, the EPEC study, which looked at antibody levels. Sorry, I'll take this away again. And it looked at the onset of eczema by age. You can see under 3 months, 3 to 6 months, 6 to 12, and over 12 months, and looking at the rates of food sensitization to any food. And you can see that the earlier the eczema was and the more severe the eczema was here in quartile, that high rates of eczema were also, severe eczema, early onset severe eczema was associated with food allergy. So if you see eczema that it's at least moderate to severe and eczema that starts before 12 months of age, you should always think about IgE-mediated food allergy. Eczema that starts after 12 months or in the second year of life is often not related to food allergy. And that's an important distinction. That's a practical point. It's not all black and white, but it's something that might guide you in your approach. But it's also important to remember that eczema is not all just food allergy. Even if you get the diet right in children with food allergy and eczema, the eczema still needs to be managed independently. And eczema will not come into remission if you get the diet right. And that's a misconception that many parents have. They say, I'm doing the diet right, my child still has eczema, so there must be something else that we're missing. Often it's just the expectation that everything can be managed with diet, and that's probably not the case. So you have to still apply all the dermatology treatments to get the eczema or keep the eczema under control. But if you get the diet right, the eczema will be much easier to control. So we have food allergy as one of the triggers of atopic dermatitis in young infants. But staphylococcal skin infection, for example, is an important trigger, and maybe even environmental allergens in older children may also play a role. Where things get confusing is when we move beyond the standard IgE-mediated food allergy and what we call the expanded spectrum of food allergy, where we suddenly see children with multiple food allergy, and I'm going to talk a little bit about that. When people talk about persistent crying, feeding difficulties as part of cow's milk allergy, reflux disease in infants, eosinophilic esophagitis, or constipation, very common pediatric conditions that may have a link to non-IgE mediated food allergy, but very hard to define and very confusing in their diagnostic workup. So I'm going to go back now and cover a few of the non-IgE mediated forms of cow's milk allergy, including FPIES, cow's milk enteropathy, and infantile proctocolitis. The symptoms of non-IgE mediated or gastrointestinal cow's milk allergy in infancy read like the textbook of pediatrics. So there's not a single symptom that cow's milk allergy could not elicit. And you can see irritability, abdominal pain, poor feeding, feeding refusal, vomiting, reflux symptoms, diarrhea, abdominal distension, constipation, rectal bleeding, poor weight gain. This is the hallmark of non-IgE mediated cow's milk allergy, but also of a lot of other gastrointestinal conditions in early childhood. And that's where often confusion arises. When should we suspect cow's milk allergy, and when is it just other common pediatric conditions? And that is something where you have to have a high index of suspicion so that you have allergy on the radar, but also have your differential diagnoses on the radar. Unfortunately, we don't have any good tests for IgE-mediated food allergy. We know many of the pathways. We know that the cytokines, interleukins 4, 5, and 13, the Th2 interleukins are involved. We know TSLP, TNF-alpha, eotaxins, mucosal IgE. They are all part of the pathway from food allergy or from food exposure to chronic inflammation in the gut or in the skin. Th2 lymphocytes, plasma cells, mast cells, eosinophils, and basophils, they're all involved in the allergic type inflammation that we see in tissue. But unfortunately, there's not a single test that we can do as a blood test or as a skin test that will give us a clear-cut answer, is this gastrointestinal food allergy or is it something else? Cow's milk enteropathy is probably the first allergic syndrome where we knew that the cow's milk could also elicit a second type of delayed onset gastrointestinal reaction that was different from anaphylaxis. And this was more common when cow's milk feeding was common practice. So before we had sophisticated formulas, so when babies were given intact cow's milk, this was more common. But with the introduction of more advanced formulas, humanized formulas, fortunately the rate of enteropathies has gone down dramatically. So in current practice, we actually don't see this condition as much as we did in the 70s or 60s. The presentation is very similar to celiac disease, and it was one of the hardest differential diagnoses for early onset celiac disease in children under 2 years of age. And that's why we still have the very strict celiac diagnostic criteria to differentiate it from cow's milk enteropathy, which histologically looks very similar. Children who have enteropathy will also become lactose intolerant, and so they have a secondary lactose malabsorption due to villus damage. And that's another area of confusion, because you can treat the lactose malabsorption and have some symptomatic improvement, but you're still not treating completely what's driving the condition. Tolerance, I wrote here, often develops by 2 or 3 years. This may be true for the non-IgE mediated forms, although there is a Finnish study that shows that some of children with non-IgE mediated food allergy have problems until school age, and we actually don't really understand or have good data on the natural history of cow's milk enteropathy. So the clinical presentation includes chronic diarrhea and vomiting and poor weight gain, basically, with markers of malabsorption, so often iron deficiency and maybe even nutritional rickets, or at least evidence of calcium malabsorption. So growth failure is really at the hallmark of complications. So poor growth and iron deficiency is often what points you in the direction of thinking about a malabsorptive condition. And this is how it might work. So we see that usually the luminal contents and the subepithelial space are separated by an intact barrier function. But if we have breakdown of the barrier function, for example, through an infective process, we might see that antigens can enter the lamina propria trigger a sensitizing event with activation of T-cell responses and then disruption of the epithelium, and this then goes in a vicious cycle of inflammation. And we see a mix of chronic diarrhea. We see osmotic diarrhea, we also see a degree of fat malabsorption, we might have protein loss, and we have mast cell activation. So it's a multi-factorial diarrhea, and if you treat these infants with a lactose-free formula, you might reduce the degree of osmotic diarrhea, but you don't stop the vicious cycle. So these patients only get better with a strict cow's milk-free diet. Another condition that you all see all the time is the infantile proctocolitis. This is a very benign condition. It's easy to treat, and it usually creates anxiety, but not a lot of morbidity. So these babies present with mild diarrhea, often bright rectal bleeding after the introduction of food, usually around the 2 to 3 week range. These babies are otherwise well, which differentiates it from other conditions with rectal bleeding, for example, enterocolitis, necrotizing enterocolitis and so forth, or infection. It does occur both in breastfed and bottle-fed babies, which highlights that antigens like cow's milk can be transferred into breast milk, and so the maternal diet is very important in this condition if you want to continue breastfeeding, for example. The histological features are activation of T cells and eosinophils in the rectal mucosa, and often the bleeding occurs from ulceration in the Peyer's patches in the distal colon. 2/3 of these babies appear to get better just with cow's milk elimination, but 1/3 seem to have more complex allergic requirements and might need a second or third allergen eliminated as well, and that sometimes gets complicated. But generally, tolerance is achieved by 12 months or even by 9 months. So this is a very benign and self-limiting process. And most babies will not become nutritionally deficient or anemic. So the blood loss is often quite minimal. So the treatment of these babies would usually be in breastfed babies a maternal elimination diet, and rarely do we need to wean these babies onto treatment formulas if the maternal diet hasn't worked. And endoscopy and biopsy, therefore, is not always required. So if we see a good treatment response, a rapid treatment response, we would usually not proceed with endoscopic investigation anymore. At least that's in our practice, because numbers are far too great and we would overwhelm your endoscopy service very quickly. But if you have a non-responder, I think you should think again. It may not be cow's milk allergy. It may actually be polyps, or it may be an early presentation of chronic granulomatous disease or other immunodeficiencies, or viral infection, atypical viral infection. So if you have a baby with rectal bleeding that does not follow your simple path, then think again, because you might not be treating cow's milk allergy. And another condition that I've only just recently encountered is neonatal transient eosinophilic proctocolitis or colitis, which is a peculiar condition, and we had one infant like that last year, where the baby had very, very high eosinophil numbers in blood and also on rectal biopsy. And this was already established before the baby had established any feeds, so the baby had profuse rectal bleeding and very high eosinophil numbers. We did the biopsy early on, before the baby started feeds, and these babies improve very quickly within 1 or 2 weeks without any intervention, and normalize their eosinophil numbers, and the rectal bleeding will stop. So I just point you to these case reports. This is a Japanese case report of this disease, which is very peculiar, very interesting, and probably not related to food allergy. And finally, FPIES or FIPES in Spanish. Food protein-induced enterocolitis syndrome, which is a peculiar acute or semi-acute non-IgE-mediated form of food allergy, which presents usually with profuse vomiting 1 to 2 hours after ingestion of a food, which makes it different to anaphylaxis, because usually anaphylaxis, the time frame is much shorter, and this condition has no skin manifestations either. The typical foods are rice and chicken and wheat, probably less common. But that's in the solids, and then cow's milk and soy from the formula. And there are 2 age peaks. The formula introduction usually a little bit earlier, and the rice and solid peak around 6 to 8 months. It does not appear to occur in breastfed babies. That's still an area of debate. There are single case reports where people seem convinced that it has occurred in a breastfed baby, but this is probably the exception. So mostly it happens after a larger dose ingestion. We have no good diagnostic tests, and we've got the investigator in the room who looked at atopy patch testing in food protein-induced enterocolitis syndrome. It may predict tolerance development, but it's cumbersome, and in our setting it hasn't been hugely successful. So we usually would just wait. If a child has had a convincing FPIES-like reaction, we would say avoid the food until at least 2 years or at least for 12 months, and then we would do a hospital challenge where we reintroduce the food under observation. The food triggers, the most common food triggers in our setting, this is a study from Sydney, from Sam Mears' group, looked at the 2 main triggers, cow's milk and soy versus rice, and it shows 2 things. The rice is often not recognized because people perceive rice as being a very safe food. So they say no one can be allergic to rice, but unfortunately this is not the case. So these are infants who had, after the first introduction of rice cereal, had profuse vomiting. And you can see that the median number before this diagnosis was made was 4 episodes. So parents needed 4 severe episodes or somewhat severe episodes to work out that rice was actually the problem. Whereas for cow's milk, people are much more tuned in, and the average there, or the median there, was 2 episodes. Also, the reactions to rice appear to have been more severe, maybe also showing that this could have been a larger dose ingested, and 40% of these infants required fluid resuscitation, which is high. So rice often not recognized and often potentially more severe than cow's milk. Another condition that I wanted to highlight is multiple food protein intolerance of infancy, which is a rare condition but a complicated condition to manage because these babies don't tolerate any food. And it's something that we've had an interest in Melbourne, just to understand not only what's driving it but also how is this best treated. These babies don't tolerate breast milk, any of the hypoallergenic formulas like extensively hydrolyzed formulas, or any of the weaning foods, or just a very small number. And these babies present with irritability, feeding refusal, persistent vomiting, chronic diarrhea, failure to thrive, and some of these have eosinophilic esophagitis as well. The symptoms only remit once these babies are treated with amino acid-based formula, and this is something that is very successful. And then with time, other solids can come in as the baby develops tolerance. Usually this is then achieved by 2 to 3 years of age. But these babies, potentially without the help of amino acid-based formula, are very sick and difficult to manage. So in your diagnostic approach, you have to be tuned in that this could be allergy, but don't be overzealous, don't call everything allergy. So firstly, try to identify a possible allergic phenotype. Either is it IgE-mediated food allergy, is it maybe FPIES, or is it non-IgE-mediated other food allergy? As a next step then, have a think about if it's gastrointestinal food allergy, the markers are often not very clear, so could it be something else? So maybe cover your diagnostics, at least to rule out things like celiac disease or other common gastrointestinal conditions. Then do a food elimination and challenge sequence just to see whether with elimination symptoms remit and with challenge whether symptoms come back. And finally, follow these patients carefully because often with gastrointestinal food allergy you need multiple time points to see whether you're on the right path towards recovery. Unfortunately, we don't have very good diagnostic tools in gastrointestinal food allergy. Often we have to rely on parent report, clinical observation, process of elimination with other gastrointestinal investigations, home challenges, hospital challenges, and rarely we have to resort to double-blind food challenges in hospital. So our diagnostic procedure is not very sophisticated, unfortunately, and good history taking, a good dietary history is very, very important. For IgE-mediated food allergy, we are in a better position. We've got IgE-mediated antibodies, food-specific antibodies that we can measure in serum, and we have skin prick testing. Both do roughly the same thing. The advantages with skin prick testing are that we can test to a greater number of foods and that we have the result pretty much instantaneously. It's also a little bit more sensitive, perhaps, than the blood testing. Blood testing is operator independent, so with skin testing you have a little bit of an element of operator dependent results, whereas the blood test is objective. A to B patch testing may have a role in some of the eosinophilic disorders, but in general we are not using it. It will be interesting what Jonathan has to say to that. He is one of the world experts on, or probably the leading world expert on A to B patch testing, so maybe we get his perspective on this. But we are not using it all the time anymore. So food elimination and challenge is really what you need to do. And with gastrointestinal presentations, you might need biopsies. You might want to look for eosinophilia, eosinophilic esophagitis. You might want to look for enteropathy. You might want to look for non-responders in proctocolitis. You have to always think about celiac disease or maybe other carbohydrate malabsorption syndromes. Skin prick testing is not an exact science. Just a reminder that skin prick testing is operator dependent. And if we have large skin prick test results, that's diagnostically convincing, but often we have small positives that we don't know what they mean, and then we need to resort to challenges. The concept of 95 predictive skin prick test diameters is an important one, and I won't have time to really go into it in great depth, but if you have a large positive skin test with a convincing clinical reaction, that makes the diagnosis of an allergy. And that's different to sensitization only, where you might have a positive skin test but not the clinical story to match it. And that's an important distinction between sensitization and allergy. So don't overcall things an allergy if you haven't had the clinical correlate. Similar to the blood test, to the skin test, we also have the 95 predictive cutoffs for the serum IgE levels. This is an older study from Hugh Sampson's group, and you can see when the skin prick test, and this has unfortunately jumped around a little bit, you can see if the skin prick, the RAST result, or the CAPFIA, as it was called then, result is up above a certain level, then we can be fairly certain, almost 100% certain, that this is an allergy. Otherwise, we might have to do challenges. Challenges are done in hospital because of the risk of anaphylaxis, so they're only needed in hospital if we have positive skin test or if we have a history of severe reactions. In the setting of a negative skin test, we often can do these challenges in the home setting. But in the hospital setting, typically what we would do is start with a small dose and escalate the dose up in the space of 2 to 3 hours. And then either demonstrate tolerance or demonstrate a food allergy. With the non-IgE mediated forms, it's much more complex, and so picture an infant with profuse, long-standing diarrhea, or chronic vomiting, and you want to work out, is this food allergy or is this maybe something else? You can use amino acid-based formula as a diagnostic tool in these infants and use exclusive amino acid-based feeding for 2 to 4 weeks. So this is for infants with severe diarrhea or severe vomiting. If the baby has ongoing symptoms, despite 2 weeks of amino acid-based formula, then it's probably not food allergy, because food allergy, gastrointestinal food allergy, would have improved by then. So you have to really go back to the differential diagnosis and see what else could it have been. Is this a motility disorder? Is this something else? But if symptoms resolve, then at least you're in a stable situation. You still don't know, is this food allergy, but it potentially could be food allergy. The next important step then is to do a challenge. And a challenge would mean to reintroduce the offending food, let's say cow's milk, and then to see whether the baby's symptoms are coming back. If they don't come back, then the problem has gone away. It could have been an infection or it could be something unrelated. But if the symptoms do recur, then you put the baby firstly back on the amino acid-based formula, get the baby back into remission, and then try with time to gradually normalize the diet. You might not need to stay on an amino acid-based formula, and you gradually de-escalate your treatment until you're back on a normal diet over time. And that may take many months, as you know. What sometimes happens, and I've observed that a few times, is that when we see response to an amino acid-based formula or extensively hydrolyzed formula, that we assume that this must have been an allergy. And that's sort of something that is understandable, but it's not always true. And I just wanted to remind you that when we change to a hydrolyzed formula or extensively hydrolyzed or amino acid-based formula, we change lots of things. We change the protein base, we often change the lipid, the carbohydrate, the energy concentration. We might have prebiotics or probiotics, or we might also just have a time effect. So there are lots of other factors in the mix, and that's why it's important that you have to have a second challenge step just to see whether was it really an allergic response that we have switched off, or was it maybe something else that we're treating inadvertently. So clinical improvement in symptoms just after formula change does not confirm cow's milk allergy. What else could it be? In our clinic, which I explained is an interdisciplinary clinic, we see a range of symptoms that are attributed to allergy but turn out to be something else. And so you have to ask yourself, is this happening with all foods, or is it maybe something that is happening to specific food ingredients like fat, carbohydrate, or other ingredients? And you see the examples of diseases here that commonly get filtered out in the allergy department. So they were referred as cow's milk allergy, but turn out to have, we had cystic fibrosis. I've fished out a few with celiac disease, congenital sucrase, isomaltase deficiency, lots of complicated differentials that might hide in the label of food allergy. So it's not always easy. When you change formula, you also change gastric emptying. Just as a reminder, you can see that human milk empties differently to formula milk. And when you look at certain specialized formula, extensively hydrolyzed formula or partially hydrolyzed formula, you can see that extensively hydrolyzed formula and breast milk roughly have same gastric emptying, but partially hydrolyzed and normal formula empty slower. And that could also explain why when you put babies on extensively hydrolyzed formula and gastric emptying improves, that reflux symptoms may also improve. So it does not always prove a mechanism. Also, when you look at the list of extensively hydrolyzed formula indications, you can see that there's a whole range of fat malabsorptive conditions, and these formulas were initially actually designed as malabsorptive or malabsorption treatment formulas before they were used in allergies. So all our extensively hydrolyzed formulas have high MCT, and they have therefore a fat malabsorption advantage. So you could maybe inadvertently treat fat malabsorption if you see improvement. So just keep an open mind what you might be treating. There's also significant overlap with lactose malabsorption. And that's what I want to finish up on, just to give you a little bit of a perspective how to differentiate cow's milk allergy, non-IgE mediated cow's milk allergy from lactose malabsorption. When you look at the list of symptoms, diarrhea, vomiting, rectal bleeding, rash, eczema, poor weight gain, they could be attributed to either non-IgE mediated or gastrointestinal food allergy or lactose malabsorption. But you can see that there is a little bit of a difference. With lactose malabsorption, you don't usually get vomiting, you don't usually get rectal bleeding, and you don't get associated eczema. So there are some features that might highlight that if you have lactose malabsorption clinically, that you might have an underlying allergic condition, particularly if eczema and rectal bleeding is present. Lactose is a disaccharide, and as you know, you need the enzyme lactase to digest it, which is only expressed in the mature brush border enterocyte. And babies are designed to digest lactose, regardless, so it's very rare for babies to be lactose intolerant unless they have a reason. So primary lactose intolerance, the so-called Finnish type lactose malabsorption, which is common in Finland and Western Russia, total absence, genetic absence of lactase, that is exceedingly rare in our setting. Adult type hypolactasia is very common, and you know it's 75% of the world population, but in infancy this usually does not happen. And then intestinal dysplasia syndromes and so forth, they're also exceedingly rare. Brush border defects, microvillus inclusion disease, and so forth. So primary lactose malabsorption in infants is exceedingly rare. What we see very commonly, though, is secondary lactose malabsorption following viral gastroenteritis, sometimes with delayed recovery, as part of cow's milk enteropathy, and as part of celiac disease. And these are the three main conditions that you have to have in the back of your head when you encounter lactose malabsorption. Is it due to cow's milk allergy, is it celiac disease, or is it post-viral? So this is what happens after rotavirus gastroenteritis. You can see that the mature villus is completely eradicated, and you lose all your disaccharidases as part of that process, as you know. Usually recovery is quick, and you see with post-viral lactase depression, usually within a week or two, people will recover. But the younger the infant and the more severe the clinical syndrome, the recovery may be delayed. And also, people who have the gene for non-persistence, so who have hypolactasia as adults, in infancy they may also have delayed recovery from gastroenteritis, and they may mimic a cow's milk allergic picture. Celiac disease I've already mentioned, and you're very well attuned to celiac disease here. Celiac disease will cause lactose intolerance, and it's also one of the main difficult differentials in the first 2 years of life from cow's milk allergy and celiac disease, because the histological presentation can be reasonably similar. And fortunately now with second or third generation serology, we have a little bit of a better diagnostic handle on it. This is the world map, old world map of lactose persistence, and you can see that, people haven't put America on this map, but at least old Australia is on here. You can see there are 3 pockets of hypolactasia, lactase persistence, so non-hypolactasia: Northern Europe, Western Africa, and the Middle East. And knowing that here in Argentina that you're mainly Mediterranean extraction, your rate of hypolactasia here is probably reasonable, or fairly significant, or fairly common. So your infants will also be more prone to have post-viral hypolactasia with delayed recovery, potentially. Australia in the same setting, so indigenous Australia, high rates of hypolactasia. And in our Aboriginal patients, for example, we see that after severe gastroenteritis, patients don't regain their lactase activity at all. So when you think about hypolactasia or lactose malabsorption, there are a few scenarios. The first one would be gastroenteritis, where you have transient villus damage. And the treatment here would be short-term lactose restriction. We usually say by 1 tin of a lactose-free formula or a couple tins, and usually then the baby is on the road to recovery. So everything should be very short-term. If it's due to cow's milk enteropathy, you have, again, transient villus damage for the time of cow's milk exposure until the baby has either gone onto the diet and you stay cow's milk free until the baby has developed tolerance. And this may be at 2 years or 3 years. The non-IgE mediated forms fortunately remit a little bit faster than the IgE mediated forms. If you put this baby on a lactose-free formula, as I already said, you will treat the cow's milk, the lactose component or lactose malabsorption component, but you will not break the vicious cycle of cow's milk-induced inflammation in the gut. If it's celiac disease, again, lactose malabsorption, you see transient villus damage. These babies will need long-term gluten restriction for the rest of their lives, and only short-term lactose restriction until the gut has repaired. And finally, those with hypolactasia, the permanent but gradual decline in lactase activity, they need long-term lactase restriction with varying degrees of strictness, because some people will still tolerate some and have residual lactase activity. So you can see lactose malabsorption in the guys in early infancy can be due to a range of factors, and it would be helpful if you think of lactose malabsorption not as an endpoint, but just as a marker for other underlying pathologies. So I'm already at summary point. So IgE-mediated food allergy is something that is increasingly common and presents with immediate food reactions, often to cow's milk, egg, peanut, but also other foods. And we're in the fortunate situation that we have good diagnostic markers for these forms of allergies in the form of either skin testing or specific serum IgE testing. So diagnostically, often not so much of a dilemma there. The situation is much different for the non-IgE-mediated gastrointestinal forms of food allergy, where we don't seem to have good diagnostic markers. These syndromes present with delayed reactions and often a chronic presentation. So in the absence of good in vitro markers, we still have to rely on food elimination and challenge sequences to make the diagnosis. And importantly also, we have to think about important common gastrointestinal differential diagnoses which we need to exclude. So it's often by process of elimination of other diagnoses that we arrive at the diagnosis of food allergy. Lactose intolerance is one of the main differential diagnoses because it's also a milk-derived food syndrome. So you have to have that in your differential diagnosis, and remember that cow's milk enteropathy, post-viral gastroenteritis, and celiac disease are the main reasons for secondary lactose malabsorption in infancy. And I finished 3 minutes early, so I beat you. Thank you.